Honor to be here with you today. Thank you for the invitation. I declared that I have no conflicts of interest, and I would like to extend my deepest gratitude to Professor Rubiano for his invaluable mentorship and for guiding the development and implementation of this project in Ecuador. Beyond one option for treatment of traumatic brain injury, a stratified protocol Bootstrap, by its English initials, is a structured clinical care model that guides the management of head trauma, providing stratified protocols adaptable to different resource levels and clinical settings. The goal is to reduce the variability in neurotrauma care, strengthen clinical decisions based on consensus of multidisciplinary experts by integrating scientific evidence. The Bootstrap protocol was first developed in Colombia in 2017, marking the beginning of a regional effort to improve TBI care across Latin America. For areas where established and continue until now, paramedics, emergency, neurosurgery, and intensive care, using Delphi methodology. Its formal publication in 2020 provided a validated roadmap for countries like Ecuador to adopt structured neurotrauma systems. The development of Bootstrap protocol followed a structured multi-phase process. The first phase is the preparation and subgroup organization. Phase 2, consensus building meeting, and phase 3, final consensus consolidation. In this phase are in Ecuador working in the consensus, in the consolidation. The final consolidation is based on these colors, and the color coding is intentional and intuitive. Green represents high resource settings, yellow indicates intermediate resource environments, and red reflects low resource context. Bootstrap has now been developed in Ecuador, in Paraguay, Brazil, and Peru. It makes and informs a growing regional network committing to improving neurotrauma care. These photos capture key moments from the Bootstrap implementation process in Ecuador, the inaugural session, the working tables organized by specialty, and finally, the consensus table where the national protocol was defined. During the consensus process, a key modification was made to the classification of traumatic brain injury severity based on the Glasgow Coma Scale, including 13 points in moderate TBI. We also realized the difference that here we have related with altitude and in relation with ventilatory parameters and even for arterial blood gas. With regard to fluid administration for resuscitation, we recommend the use of hypertonic solution at 4% because of the facility at the moment of the preparation. We established the use of tranexamic acid, hyperosmolar solution, glucose levels, and the treatment of seizures, also the analgesia and sedation. We recommend the use of whole trauma checklist and the criteria for transfer that are listed in the first protocol. In centers with resources for invasive or non-invasive ICP monitoring, we recommend to do it and also dictate the surgical indications for traumatic brain injuries and propose a definition for primary decompressive craniectomy. And remember that we are evaluating all the possible scenarios. So if you have neurosurgeon but you don't have ICU, we suggest to perform hourly postoperative neurological examination and images studies. In centers with high resource, consider secondary cranial decompression if ICP is refractory to medical treatment under non-invasive or invasive neuromonitoring measures or biomarker index. In conclusion, the Bootstrap model represents a collaborative evidence-based effort to optimize traumatic brain injury care in diverse and resource variable settings. Its implementation across Latin America has proven to be a valuable tool for reducing gaps in care delivery, strengthening clinical capacities, and improving decision-making across all levels of the healthcare system. This protocol not only enhances clinical outcomes, but also fosters regional collaboration and adaptability, key elements in advancing neurotrauma care in our communities. Thank you.
Thank you so much, Dr. Piedad Acurio. It was great talk. Congratulations. We can maybe leave some questions in the end of the session, and if we have time. So we need to go on with the session. The next speaker I would like to invite is Dr. Dhaval Shukla from India. I hope I pronounced this name correctly, with the talk in near-infrared spectroscopy in brain trauma.
Dr. Dhaval Shukla is not here.
He's not here. So I think we can go on and continue with the next speaker, if he's here or she's here, Dr. Aderheim Haidara for Ivory Coast with a discussion. So we can continue.
No, he is not here as well. So you can discuss.
Okay, so we can discuss with these topics we had before. I would like to ask the speakers to unmute themselves. Dr. Yonsi from Germany and Dr. Acurio from Ecuador. I don't know, is Dr. Horlock from USA still available? Okay, I think I have a first question for Dr. Alexander Yonsi from Germany. I would like to ask you to some kind of conclude again about your post-op protocol you have in your country, because it's all the time is the discussion between acute suction of the subdural hematoma or passive suction after the evacuation. So, what's your insights of the topic?
Okay, I mean, as initially stated, so there's a lot of different strategies and unfortunately not so much evidence, although there are more and more relevant studies on this topic. For the drain topic overall, we stick to subdural drains, although there's some evidence for the subgaleal drain as well, and we use passive suction, so this is no active suction. And the length of drainage has been reduced over the last year. So nowadays, evidence points to 24 hours being sufficient, and also mobilization really directly or early after the surgery. I mean, it's many times old patients, so it is other problems, but even more importantly, mobilization can be performed. And the bag is placed on the heart, fixed with a tape, and patients stand up. There is a risk of pneumocephalus, but with this kind of management, it is less than leaving the patient in the bed and then having them stand up maybe at night unobserved with the bag attached to the bed or something that creates more problems. And that's our experience.
Okay, thank you so much. I think it's pretty controversial, but in our country, maybe we're doing all the time subdural drain, and sometimes we use active suction on subdural drain, but you need to be very careful with management of the suction. Sometimes, that kind of like irritation of the dura or cortical force can occur, and we had some kind of experience with I think 2 or 3 patients with epileptic seizure, but I don't know if it's just because of the active suction or there was like actual irritation of the drainage on the cortical surface. So that's just our insights from our department.
In relation to what you were mentioning, we had an experience with the subdural drainage, and we just move off, and the convulsions, the seizures stopped. So I think that the pressure that it can occur over the drain can lead to seizures also.
Definitely, yeah, and even more problems. But I mean, everybody has seen the drain place into the central cortex. But I mean, what is a counter-argument against the subgaleal drain is that if you look at the evidence, you would need 2 burr holes, and usually we just perform 1 to make this effective. So, yeah.
What we made is a mini craniectomy temporal with both drainage, one directed to the frontal and the other one to occipital, and we have good results.
Okay, thank you. May I ask you one more question about the post of CT? If you are doing, because Dr. Junsi, you told us that you are doing only, or if I catch it like correctly, you're doing this the post